In the new 2024 Maryland Medical Protocols, you will find several changes specific to treatment of pediatric patients. Most notable are modifications to the ventricular assist device and stroke protocols, administration of TXA for shock due to both trauma and postpartum hemorrhage, and the needle decompression thoracostomy procedure. As you will see, the first two changes apply to both BLS and ALS clinicians, while the remaining two are specifically ALS. Let's take a look at each of these changes. Since it was introduced into Maryland Medical Protocols in 2022, use of the ventricular assist device, VAD, protocol has been limited to adult patients 18 years of age and older. With the 2024 update, the VAD protocol now applies to patients of all ages. As you can see, we have updated the references to other relevant protocols for adult and pediatric patients. For ALS clinicians, also keep in mind that pediatric VAD patients may be volume sensitive. To that end, give small fluid boluses of 10 ml per kilo to a max single bolus of 250 ml as needed for hypoperfusion. Scanning the protocol, you will find the other important addition, the contact numbers for pediatric VAD coordinators at Johns Hopkins Children's Center, University of Maryland Medical Center, and Children's National Hospital. Just to review, please remember the following pearls when treating a patient with a VAD. Your VAD patient might not have a palpable pulse or detectable systolic or diastolic blood pressure. An automated blood pressure cuff may be used to obtain a MAP or mean arterial pressure. If your patient is unresponsive, not breathing, has delayed capillary refill, and you are unable to obtain a MAP reading, you should perform high-performance CPR using only manual chest compressions. Mechanical CPR is contraindicated for VAD patients. Contact the patient's VAD coordinator or their VAD-trained companion, parent, or guardian for additional information regarding the VAD or most appropriate destination for the patient. Scenario: you are caring for a 14-year-old with a VAD who is unresponsive, not breathing, and has delayed capillary refill. You are unable to obtain a MAP reading using your automated blood pressure monitor. Your next action should be: A. Obtain a blood glucose reading. B. Initiate high-performance CPR with manual chest compressions. C. Contact the patient's VAD coordinator. If a mechanical CPR device is available, mechanical CPR is preferred over manual CPR for this patient. A. True. B. False. The modification to the 2024 stroke protocol is not something you will see, but rather something that was deleted. In the past, clinicians were directed to administer oxygen at 2 to 6 liters per minute by nasal cannula for all pediatric stroke patients, even those not demonstrating signs of respiratory distress or hypoxia. Evidence no longer supports this practice, so this recommendation and a corresponding pediatric panda symbol were removed from the BLS section of the stroke protocol. For both adult and pediatric stroke patients, oxygen administration is only indicated for patients experiencing signs of respiratory distress or hypoxia, such as SpO2 below 94% as indicated under general patient care. You are caring for an 8-year-old female patient with a history of sickle cell anemia. She appears to be having a stroke with slurred speech and right-sided weakness, but denies shortness of breath. Her respirations are unlabored, and her room air pulse ox reading is 98%. Your treatment should include oxygen at 2 to 6 liters per minute via nasal cannula. A. True. B. False. In 2022, we added tranexchemic acid, TXA, for the treatment of adult patients 15 years of age and older with symptoms of shock or hypoperfusion secondary to trauma. Last year, we expanded the use of TXA to include patients 15 years of age and older in shock secondary to postpartum hemorrhage in addition to traumatic injury. Now, the 2024 protocols further extend the use of TXA to include pediatric patients. You will find these changes incorporated into the Pediatric Shock Hypoperfusion Protocol and the Obstetric Emergencies Childbirth Algorithm, as well as the TXA pharmacology page. Looking through the TXA pharmacology, you will see that the indications for administration remain suspected hemorrhagic shock due to either traumatic mechanism or postpartum hemorrhage with ongoing blood loss despite uterine massage. Traumatic injury or delivery must have occurred within the past 1 hour. What has changed in the indications is the addition of pediatric systolic blood pressure guidelines. For trauma patients, indications of hemorrhagic shock include systolic blood pressure less than 90 millimeters of mercury for patients 12 years of age and older, or systolic blood pressure less than 70 plus 2 times the patient's age in years for patients less than 12 years old. For postpartum hemorrhage, indications include systolic blood pressure less than 90 or heart rate greater than 110 for patients 12 years of age and older, or systolic blood pressure less than 70 plus 2 times the patient's age in years for patients less than 12 years old. Contraindications are unchanged: hypersensitivity to TXA and known arterial or venous thromboembolism, PE or DVT. Adverse effects remain the same: hypotension if given faster than 100 milligrams per minute, and seizures. Also unchanged are the precautions: administer over 10 minutes to reduce the risk of hypotension, and do not delay transport to administer TXA. Dosage has been adjusted to include age-based pediatric dosing. For patients 12 years of age and older, administer 1 gram of TXA in 100 ml of approved diluent, normal saline, lactated ringers, or D5W, IV/IO over 10 minutes. For patients 5 through 11 years old, administer 500 milligrams TXA in 100 ml approved diluent, IV/IO over 10 minutes. For patients less than 5 years old, a medical consultation is required. Your 6-year-old male patient was the back seat unrestrained passenger in a high-speed MVC that occurred 30 minutes prior to EMS arrival. He has an obvious contusion on his chest and his abdomen is distended and tender on palpation. His vital signs are blood pressure 60/30, pulse 150, respiration rate 40. His room air pulse ox reading is 90%. Your treatment should include administration of TXA for shock. A, true. B, false. The correct dose and delivery method are A, 1 gram TXA IV/IO rapid push. B, 1 gram TXA in 100 ml approved diluent, IV/IO over 10 minutes. C, 500 milligrams TXA IV/IO rapid push. D, 500 milligram TXA in 100 ml approved diluent, IV/IO over 10 minutes. Our final pediatric change for ALS clinicians is in the needle decompression thoracostomy (NDT) procedure. Recent research regarding the length of catheter or needle most appropriate for use in pediatric patients shows that the standard 3.25-inch 14-gauge catheter is too long for our smaller pediatric patients. In section 12.7 of the procedure section, you will find the modified NDT procedure. For patients 15 years of age and older, the procedure and equipment are unchanged. Use a 3.25-inch 14-gauge needle or catheter with an optional flutter valve. The preferred insertion site is the 5th intercostal space at the anterior axillary line. If the 5th intercostal space is unavailable, use the second intercostal space at the midclavicular line on the anterior chest wall. For pediatric patients who are at least 4 years old and less than 15 years of age, you will continue to use a 3.25-inch 14-gauge needle or catheter, but the preferred insertion site is the second intercostal space, the midclavicular line on the anterior chest wall. For our youngest patients, those less than 4 years old, we will now use a standard 16-gauge IV catheter. Length will generally be 1.16, 1.12, or 1.25 inches. As with the 4 to 15-year-old population of pediatric patients, the preferred insertion site is the second intercostal space at the midclavicular line on the anterior chest wall. You are treating a 3-year-old male patient who was trapped under his older brother's ATV. On extricating him, you find that he has a large contusion over his chest wall and absent lung sounds on the left side. He is unresponsive with a blood pressure of 60/35, pulse 145, respiration 60, shallow and labored, and a room air pulse ox reading of 80%. Treatment should include A. Needle decompression thoracostomy on the right side. B. Needle decompression thoracostomy on the left side. C. High-performance CPR. You choose to perform needle decompression thoracostomy on this patient. The correct catheter size and insertion site are A. A 3.25-inch 14-gauge catheter inserted in the 5th intercostal space, the anterior axillary line. B. A 16-gauge 1.25-inch IV catheter inserted in the 5th intercostal space at the anterior axillary line. C. A 3.25-inch 14-gauge catheter inserted at the 2nd intercostal space at the midclavicular line on the anterior chest wall. D. A 16-gauge 1.25-inch IV catheter inserted in the 2nd intercostal space at the midclavicular line on the anterior chest wall.